Good morning, everyone, and welcome. I'm Sarah Cott, Senior Vice President of Programming at The Hill. Thank you all for joining us in person this morning, and thank you to everyone joining us online for our event, Prescribing PBM Reform, Accelerating Transparency with Bipartisan Action. I'd like to thank our sponsors, Transparency RX, for their support of this discussion. We are here today to discuss pharmacy benefit manager reform. Just days after the White House convened a roundtable on this very topic, PBM reform has emerged as a bipartisan issue in a divided Congress. However, the issue did not make the cut in the most recent government funding bills, as some has hoped. With so many complex ideas and possible solutions on the table, how and when should Washington increase PBM accountability to make sure employees and patients aren't overpaying for their prescription medications they need? And what role will transparent PBMs, alongside all stakeholders in healthcare, play in driving that change? Before we get underway, a few housekeeping rules. If you're in the audience, if you could please turn your cell phones to silent, and you're welcome to join us on social media at The Hill events using the hashtag HillHealth. And with that, I am delighted to welcome Bob Cusack, The Hill's editor-in-chief, to the stage. He will be moderating our first interview with Congressman Jake Auchincloss of Massachusetts, co-sponsor of Protecting Patients Against PBM Abuse Act. Thank you, everyone.
Thanks, Sarah, and good morning to everyone. Thanks for coming as we're live streaming on thehill.com. Big night last night, Congressman. I want to get kind of news of the day. What was your reaction to the results? We were talking earlier, not a huge surprise, but what was your take?
Biggest takeaway is Trump has if we think about this as Super Tuesday is the last date before which both President Biden and former President Trump are rallying their bases before heading into a general election. In that rallying of the bases, Trump has a much bigger problem than Biden does. There is no never Biden cohort within the Democratic electorate. There is a never Trump cohort within the Republican electorate. And while that never Trump cohort is relatively small, it is persistent. And it is, I think, unpersuadable to come back to him. So the math is much more in favor of Joe Biden than in Donald Trump right now.
Are you confident we're going to avoid having a government shutdown? As you know, Congress has punted and punted and punted, and now it seems like it's closer than ever to actually get bills enacted that are not just punts.
I don't use the word confident in the 118th Congress. I don't know if how many of you have met our speaker, but he does not inspire confidence. He is just totally a deer in the headlights and doesn't have control over his conference. He's obviously relying really on a de facto governing coalition of both parties, but he refuses to admit it or to actually operationalize it and turn it into an asset rather than a liability. And so everything is going to be careening from, his failures to make decisions on big items. So I'm not confident on anything. Yeah, there's a deal in place, but let's get it to the president's desk.
You've been a leader in attempting to lower prescription drug costs and PBM reform. How did you get involved in this issue?
So I represent Massachusetts, which is the life sciences capital of the world. And I grew up in a family of scientists. My mom was a pioneering cancer researcher, grandfather, dad, brother, stepfather, all of them involved in research. And one thing that's made me appreciate is that the quality of the science is more exciting right now than it's ever been. Everyone talks about AI and the potency of AI to transform our world. I actually think relative to AI, CRISPR and gene editing and our understanding of biology and our ability to turn biology into an engineerable discipline is more exciting as a general purpose technology than AI is. 50 years from now, we'll be reflecting on biotech as actually more of a game changer than artificial intelligence. And obviously there's confluence between the two. But I have tremendous respect for biomedical research and development, but my frustration has been that there is this chasm between how exciting the science is and the patient experience of that and patient access to the fruits of those discoveries. And as you dig into why that is, before long, you stumble on PBM reform.
Mm-hmm. Well, speaking of which, PBM reform was not included, as you know, in certainly the first set of funding bills. lawmakers who really want to get this done this year, including Senate Finance Committee Chairman Ron Wyden, very disappointed in that, pointing to the lame duck. Is the possibility in the lame duck, or could it be done beforehand?
It could be done in the lame duck. It could be done beforehand. Some of those decisions are happening in rooms, frankly, that I'm not invited to. I would go back, though, to my statement about the 118th Congress, and I would just have a baseline expectation that it's going to be very hard to pass policy in the 118th Congress, where we've got an incompetent speaker going into an election year, or in an election year going into an election. My view on a lot of this is, yeah, be ready for whatever legislative vehicle comes, and we're working on PBM legislation and trying to build a cross-sectional coalition behind it in the House Democratic Caucus and with bipartisan support as well. But I am also oriented to next Congress and ACA tax credits and other potential vehicles to move reform on. I just think it's very unwieldy right now. I mean, look at the tax bill that we passed in the House, right? Big bipartisan majorities for that tax bill.
Right.
And kind of deflated in the Senate. So there's just, mechanically, it's just very challenging right now.
But also, there's literally dozens of PBM reform measures that are pending. And what is going to be the vehicle in the end all? Because this is a bipartisan bill, yeah. Both in the House and the Senate. But what is the bill that's going to move? Because you're a co-sponsor of many of them.
So what I've learned in 3 years in Washington is that the who and the what of policymaking is hard but relatively straightforward, meaning figuring out what kind of policy you want to do and the coalition to build around it is kind of mechanical. You plow through it. Figuring out the when is the fruit of decades of experience on the Hill. And so you're asking me the when, and the candid answer is I don't know. And it's going to require people like Richie Neal and Hakeem Jeffries and Senator Wyden, I think, to get aligned on how to move it. The clear horse in the stable that has to go around the track, though, is the ACA tax credits next year.
Right.
That is a clear Democratic health care priority, and things that get attached to that, I think, have the best chance of flying.
So now in this Congress, PBM reform definitely made some significant strides. As you say, remains to be seen whether it's going to get done. Probably not before the election, maybe in the lame duck. But you think that one way or the other, next year, when you have a lot of, whether it's expiring tax credits, I mean, you have the vehicles there, you think it'll get done at least sometime next year?
At this point, when you've got legislation that is vetted, bipartisan, and at least elements of it are saving money, it's hard to me to see how that sits on the table for too long. At some point, there's a package where that gets picked up and added on to it. I do have confidence that we are doing PBM reform legislation in the next term or two. It's also worth, though, taking a step back and just, because PBM reform is a very, very big term, right? There's a lot of things that go in there. And when we say PBM reform, obviously the devil's in the details. Like, what are the things that we're really talking about? To me, the absolute keystone policy within that is going to be delinking both in the Medicare and in the commercial markets. There's a lot of other elements in there, spread pricing and steering and DIR reform and benefits consultants, and there's a lot of elements. But the very, very core of it, and I think probably the thread that has to be pulled on and gotten alignment around first, is that delinking element. And that was probably the biggest challenge, I think, in these PBM reform negotiations this last month.
Now critics of PBM reform legislation say, well, if you make those changes, and it is nuanced, it's complicated, but that it could be whack-a-mole where PBMs could raise administrative costs. So if you're getting rid of the delink part, other issues could pop up. And someone's celebrating early for PBM reform. But what about that criticism? As you know, this has been an intense lobbying battle. The pharmaceutical industry very involved, obviously the large PBMs involved.
Yeah, and this is going to be the big stick the PCMA and others are going to swing, which is, hey, wait a minute, you make us change, rebate pass-through, or you make us change spread pricing or steering, and we're going to have to raise premiums.
Right.
And I want to give two answers to that maybe even three answers to that. One is, I think we need to empirically demonstrate counterfactuals and go out there to, Troy Medicare in North Carolina or Scan Insurance in California and be like, I'm looking at examples right now of companies that have zero deductibles, zero copays, and they're not raising premiums. So, onus is on you, Fortune 10 company, to explain to us why that is true for you. The second answer is political, which is to say, I would love to get into a debate with United Healthcare as a politician about whether my attempts to lower out-of-pocket costs for patients by eating into some of their $7 billion of quarterly profit is more popular than their attempts to raise premiums on Medicare Part D beneficiaries because we're forcing them to be more transparent. Let's have that fight. Democrats had that fight during the ACA with the health insurance companies. We won. One of the biggest accomplishments of the last 20 years was the ACA, and we took on the corporate greed of the health insurance companies to do it. We should be begging to get into that debate with United Healthcare. I walk into town halls throughout my district, and I lay this directly on the table. This is a winning issue, and I think we should welcome this opportunity to show the American people that we are fighting integrated monopoly power to lower prices for them.
What about the claim, hey, the PBM reform is really just distracting from the profits of the pharmaceutical industry? In this country, we have healthcare for profit. Some people don't like it, but that's the way it is. What about that? And obviously the effect of the Inflation Reduction Act, which the pharmaceutical industry was not fond of. Do they assume some responsibility here too?
Definitely, and the pharmaceutical companies need to drop these lawsuits against the IRA. Frankly, the judges are kind of making them look silly right now by dismissing a lot of their claims out of hand. And I think these pharmaceutical manufacturers, if they want to be able to work in good faith with members of Congress in both parties on concerns that they have, suing CMS is not a great way to start that conversation. There's nothing unconstitutional about Medicare as a buyer, exerting their leverage as a buyer. I think their First Amendment and Fifth Amendment claims are just really, to me, they're not cutting it. Mm-hmm. But to answer that question more foundationally, I do think it's worth taking a step back and thinking to ourselves, how do we want the drug industry to work? It's very easy as a politician to criticize how things are working now, and I certainly am willing to do that. But I also, I think, have the onus of presenting what do I want the world to look like? And the way I view it in my head is, in a functioning drug pricing marketplace, you have in the foreground the patient, the pharmacist, and the scientist. And the scientists are competing for the very best biomedical advances that treat both chronic and acute conditions for the patient. And they are ferociously competing amongst themselves for who can get that drug to market under the strict auspices of the FDA. And there's healthy competition there. And these pharmaceutical companies are evaluated based on the quality of their R&D. On the other side, you get the pharmacists. And the pharmacists are competing to provide high-quality services to patients in the dispensation of these drugs. It's not just kind of moving pills from one bottle to another. It is being true community pharmacists, where they're able to provide consultation and care to patients. And patients are going to vote with their feet about which kind of pharmacist is providing that kind of service. That's the way I want things to work, where the patient is at the center and you've got pharmacists and scientists competing in a market system to deliver the best both cures and care to that patient. The way it works now, though, is really the insurance companies are in the foreground. And through steering and through networks and through the fact that list prices feed so much downstream revenue for hospitals and for plan sponsors, the PBMs are the ones who are in the foreground and who basically have a command and control view of the market. And that is what we have to break. And the way to break that, it's multifaceted, but the core of it is, I think, going to be delinking.
The White House this week had a listening session on this issue. Would you like to see this mentioned in the State of the Union? Do you like to see the White House really take this and say, hey, we can get this done this year as opposed to next?
Yeah, although I don't want the president to commit to things that he's totally dependent on Congress to do, okay. Right? So I want to be cautious of his political capital. I think the president probably needs to focus his State of the Union on telling the story of what's already happened with costs stabilizing and, in fact, real wages going up over the last year and a half, and also putting his hand out again to Republicans to say, come fix the border with me, and letting them again say, no, we want to campaign on the border, not govern on the border. I think that's probably got to be where the focus of his State of the Union is at. To the extent that he's talking about drug pricing, frankly, thinking politically again, I would just remind voters what he's already done. The last time I checked, fewer than half of Americans actually knew that we empowered Medicare to negotiate drug prices. Fewer than half of Americans were aware that their Part D costs are now capped at $3,500, going to $2,000 next year. Like, we don't have to make promises. We can literally just point to what we did.
But that's also a bit of a problem, because with any healthcare legislation, including which I covered the creation of Part D, it took a couple years to set up. Same thing with the IRA. People are not quite seeing it. So how do you massage that message?
Well, people are going to see the $3,500.
That's true.
That's in effect this year, and particularly that cancer patients are going to benefit from that disproportionately. And I think there's a strong and potent story to tell about that. And then I think there's also, and this is not the most appealing feature of politics, but it just is true, that sometimes voters define things through the fights that are getting picked. And when they see pharma suing the administration, they may not know why the pharma is suing the administration, but they take that as a sign that somehow a fight is being picked on their behalf. And I think that the administration is doing this. They're going to use those lawsuits to their advantage. It's another reason I would tell pharma, like, strategically here, I'm not sure you're doing yourselves any favors.
Regarding savings and people watching this, we've got a lot of stakeholders in the room, kind of insiders like me, but a lot of people watching who just want their drugs reduced.
Yeah.
So how can we ensure with PBM reform that the savings are not going to be passed not to the consumer but to somebody else?
Well, part of it is legislative. So in the legislation, that some of it's already out there and some of it we're working on, there is mandatory pass-through of 100% of the rebates, right? And being very strict about the definitions of what counts as an admin fee versus what counts as a rebate, right? Because we all know what's going to happen is the PBMs are going to say, all right, we won't do rebate pass-throughs. But it turns out that our admin fees are actually predicated on A, B, and C, and D, which have suspicious correlation with the list prices, right? So we have to be extremely rigorous in basically putting in statute the anti-kickback rule, right? Which is really like the fiduciary idea that PBM should have a flat, transparent rate and not be linked to list prices. Because right now we have a situation where higher list prices feeds a lot of downstream entities.
And as far as people who are pushing for this bill to pass, whether it's this year or next, what do you encourage them to do, constituents or otherwise?
Talk to CBO. The biggest thing that we've got to work on is we need the Congressional Budget Office to have a more nuanced appreciation for what a fully, the marketplace that I described, where you have scientists and pharmacists competing to provide cures and services to patients. CBO needs to more holistically internalize the benefits of that in how they score things, because so much of this is really not even going to come down to politics, because largely the politics is there. There's bipartisan support for a lot of this. It's going to come down to how to pair up offsets and expenditures. And until CBO starts giving scores back that reflect what I think are really the long-term savings of a better functioning drug pricing marketplace, it's going to be hard to get this stuff across the line.
And that has been a problem with CBO that lawmakers have complained about for a while.
Yeah, but we see the CBO now thinking, I think, more progressively about a lot of issues. Immigration.
You've seen some change recently.
CBO is certainly assertively going out there and saying, help us think differently about these things. We're seeing it with immigration. We're seeing it with cell and gene therapies. We're seeing it even, I think, with the GLP-1 inhibitors, and like, what's the true offset going to be in terms of if you reduce the incidence of diabetes, right? So I think CBO, to their credit, they're rigorous, right? They want to see evidence.
Right.
So we're going to need some good peer-reviewed papers out there that show CBO, hey, this is actually, don't buy the PCMA argument that premiums go up and we all pay more. Look more deeply.
Mm-hmm. Not many things get over 300 votes in the House, whether it's the tax bill or PBM reform, but then it has to pass the Senate, doesn't it? And that can be frustrating.
It's got to pass the Senate, or it can go the other direction, right? And Senator Wyden can tell you something can pass unanimously in finance and be a very well-vetted bill, and then kind of fall apart in the four corners.
Right, just get stuck. Well, Congressman, thanks for joining us this morning. Please thank the Congressman for joining us. Thank you so much.
Thank you, Bob. Thank you, Representative Auchincloss. We've come to the sponsor perspective portion of our program. Please welcome Lynn Riley, President of Pharmacy Benefits Dimensions, and Leanne Boyd, founding partner and CEO of Levinti, in conversation with Kathleen Koch.
Thank you, Sarah, and good morning, everyone. And Leanne and Lynn, thanks for joining me. So in that conversation, we just heard about some of the proposed reforms, PBM reforms, that Congress is eyeing to help reduce prescription drug costs, right? Now, you are both CEOs of PBMs, yet you support reform in your own industry. Help us understand that.
Sure, absolutely. As PBMs that operate in many ways that are consistent with a lot of the measures in the proposed reforms, we are very much in support of the reform out there. We believe it's the right thing for patients, the right thing for plans, the right thing from employers, all facets of the industry. We believe strongly that it does help lower pharmacy costs. We see it in our practices every single day. It's one of the reasons why we've banded together in forming Transparency RX, our coalition that gives us voice in the marketplace about how we do practice PBM and have been operating with these business practices for quite a long time.
Yeah, so a little bit different perspective on our end. So stepping back, we were actually founded by asking many of the questions that are being asked today. And so we were actually started by 2 graduate students at the university who this was their thesis, who said, how can we change our community and the healthcare? And in the 90s, they turned their attention to drug costs because they were starting to rise. And the answer that they kept coming back to was the PBM as one of the biggest barriers to information, and as well as not being able to see what was actually happening with drug pricing.
So it was evident early on.
Early on. I'll go back to the days Lipitor had just hit the market. It was a big blockbuster then. And so trying to figure out how to constrain those drug costs. And the answer all the way through as one of the biggest costs to the plan, as well as one of the biggest barriers, was actually the PBM. And so they brought everything in-house and started doing it themselves. And so we have been doing a transparent model for 30 years. So this works. What we're trying to do today and what's happening in terms of reform and the model that Leanne has, it works. And we've done it for 30 years very successfully.
So you are then what are called transparent PBMs. Can you help us understand what that means? Because it does sound like you operate very differently from the large 3 PBMs that currently control roughly 80% of the market.
Yeah, that's correct. We do operate very differently from the market that's dominated by that 80%. To keep it very, very simple, it really comes down to our revenue models. And in the case of Levinti, we are a pass-through transparent business model. We charge a simple admin fee for the services we provide to our patients. Every bit of discounts, every bit of price concessions get passed through down to the patients and to the plans that are funding the pharmacy benefit.
And your fees have no linkage to the cost of the prescription
Correct.
drugs?
So
Wow.
as contrast, other PBMs will have many forms of revenue. We heard a little bit about spread, which is a markup of the drug at the pharmacy counter. Rebates is a big piece. All of those link very, very closely to the cost of the drug. And
the rebates are where the PBM, the larger ones, keep the rebate and don't pass it on to the consumer.
Many will keep large portions of those rebates and link very closely to the price of the medication. Many are focused on specialty medications, encouraging the high utilization of those very, very expensive medications that drive a lot of rebates. So there is quite a difference between our revenue models when you compare the traditional PBM in the marketplace versus a transparent PBM.
Did you want to add to that?
I'm going to add on with a couple examples because everything Leanne said is correct and pertains. So example, if we're talking about patients, we recently had a new client come on first of the year with us, and one of their members called us and said, I have not started my breast cancer medication because I can't afford it through my previous employer who had one of these other PBMs. And she said, what can I do? And I haven't even told my physician I haven't started it yet. So we looked up the cost of the drug. They were going to charge her $4,000. And we looked up our
4,000
4,000
a month?
A month, correct. And we looked up our cost, it was 300. So that is the difference that Leanne is referring to in that spread pricing, that difference. So either that PBM was, really, really bad at negotiating drug prices, or they were, taking that profit and putting it somewhere else. And so, that is what we're talking about in terms of those differences. They're big, meaningful dollars that have a difference in patient care.
So then, this means that companies that utilize transparent PBMs like yours can realize a dramatic savings and then pass that on to their patients. Explain to me, is that how it works?
Absolutely. By eliminating many of those layers of cost in that revenue model, eliminating spread completely, immediately patients can realize lower drug cost at the pharmacy counter. With passing through things like rebates to plans, to patients. It helps with the premium conversation. And the last piece is just really helping plans and patients choose good, clinically effective, cost-effective drug options, as in the case of Lynn's example.
Now, Lynn, I assume that you wouldn't be here, the two of you, if your companies weren't both thriving, weren't both making a profit. So is it the case that, that your companies are actually sort of living proof that these reforms Congress is eyeing, that they can work?
Yeah, I'm going to jump in. Absolutely. I mean, I started as the intern. I was there when these conversations, I know I just aged myself in this room, but I was the intern listening to these conversations in the early 90s and how they were going to do this. And so I absolutely think that this is living proof that it can work 30 years later, and we've been able to manage costs, even so much so that we're seeing that impact our community, going back to that question of how can you impact the community. So one of our school districts, who's part of a coalition in Buffalo, joined and moved to this transparent model. And with the savings they had alone, they were able to add an extra teacher. So that's a huge impact. That's creating jobs, that's educating our children, just in what they saved in drug pricing, which, that doesn't seem right, but it's how this world we're living in is working, where you're choosing between, a teacher, a job, or paying, a PBM, and that's not how it should work.
Now, the two of you, between you, have more than 42 years of experience, right, leading PBMs, and you have seen the market change, the industry change. Talk to me about how tough it has been to buck that trend that has so enriched your largest competitors.
Sure, it definitely has been a journey. I think when we first started, we're closer to 13 years in the industry. When we first started, it was just even the conversation of, can pass-through transparent PBMs be viable in the marketplace? Can they really deliver lower cost? Fortunately, we've exceeded that ability to demonstrate our value we bring to clients. But there's a lot of barriers that are in the marketplace still today. Plans being able to access their data so they can look at what costs may be with other options in the marketplace, create barriers to that competition, the ability to shop for your PBM services, the ability to even do a lot of flexible plan designs. There's a lot of things that prevent employers or plans from making decisions and pursuing a different type model today.
So, Lynn, I know that you are both part of this, this coalition that is pushing for change. So what comes next? What are you hoping to see?
I'm hoping to see some of what we've been doing actually make it into a level playing field, to get past not just on the government side, but the commercial side as well, of spreading this true model, this transparency, access to data, being able to see what you're paying for, make decisions about healthcare based on your actual spend and your actual drugs, and not just be blind or taking somebody's word, and having that spread across everybody in the country, not just segments of it. So I'm really hopeful for a comprehensive solution that sets a level playing field, really encourages free market. We struggle with the same things Leanne just said, and be able to go out there and say, okay, this is another way, and yes, you have the ability to have this option. Take away those barriers.
And when Lynn talks about a comprehensive solution, it's so important because we've witnessed it now for decades, where the reference to playing whack-a-mole, if you don't have comprehensive enough reform, it will just shift. And so there are offshore affiliates of PBMs that kind of help shield some of the rebate dollars we were discussing. And so to me, what's next is making sure we do have a comprehensive enough solution out in the marketplace.
Thank you so much, Leanne Boyd, CEO of Avinity, and Lynn Riley, President of Pharmacy Benefit Dimensions. We really appreciate you sharing your point of view with us today.
Thank you.
Thanks. Thank you all.
Thank you, Lynn, Leanne, and Kathleen, and thank you again to Transparency RX for their support of today's program. If anybody who's come in late would like to take a seat, we'll pause for a moment before we start our next panel discussion. All right. Now please welcome back Bob Cusack, who will be joined by 4 very important voices on this topic to discuss the path forward on lowering drug costs and what's next to expect from PBM reform. Anthony Chacha, president of 3 Axios Advisors. Dr. Marina Sokal, associate scientist at the Department of Health Policy and Management at Johns Hopkins Bloomberg School of Public Health. Amy Inahopsa, president and CEO of MANA, and James Gelfand, president and CEO of ERISA Industry Committees. Welcome, everyone. I hope I got that.
Thank you, Sarah. Why don't we go down the lines, James, starting with you, if you can briefly kind of introduce yourself, your affiliation, and your passion for this space.
Sure. James Gelfand with the ERISA Industry Committee, or ERIC for short. We represent the large employers who provide benefits to their workers and to the families of their workers. These are companies that make widgets. They are not health insurance companies, but they have to run these plans. And they tend to contribute about 75 to 80% of the costs of health insurance on behalf of the people who work for us and their families. So we hire PBMs to help us run those plans. We can't be negotiating with hundreds of pharma companies every year and trying to track the fluctuation of those prices. And the understanding is that they would work for us and they would help us to achieve affordable coverage for our employees. But what we're increasingly finding is that there's a conflict there and it's not working the way that it's supposed to work. Part of that is because while an employer is a fiduciary to their health plan and we have to do right by the people in that plan, our vendors don't share that responsibility, meaning that they're there to make money for their stockholders, not necessarily to get cheap drugs for the employees. They're taking money from both sides as well. So at the same time they're supposed to be negotiating against Big Pharma, they're charging big fees to Big Pharma. Fees for things like the privilege to negotiate or to be stocked at a given specialty pharmacy, which the PBMs also own. And what we're finding is that change needs to take place in order for us to get health insurance costs and prescription drug costs under control. And to say that we need to make change to PBMs does not mean that there's no change needed for the drug companies, right? We still believe that major changes are needed for patents and at the FDA too. But you've got to take these things on one at a time or you're going to get nowhere. We're also, big believers in the free market. We know that free markets will help to drive down costs and get the most efficient products to our employees at the best prices. But when you have 3 companies that control 90% of a market, that's not a free market. That's an oligopoly. And so that's where we need government to step in and say, we're going to set some rules of the road to make this work. And if you don't believe that it's not working, all you need to look at is the biosimilars that came online for Humira. This is the highest grossing drug ever. The very day that a single competitor to that drug came on the market, you should have seen massive change. But what did you see? Someone can correct me on the panel, I'm sure, but I think it's about 2% market share has gone to those biosimilars. And the other 98% is staying with the super high cost drug. Why? Well, because the vendors who are setting these formularies and who are deciding who gets steered to what drugs, they want the higher cost drugs. So there's something that's broken here, and the employers are dedicated to trying to fix it.
Well, we'll talk about what's broken.
Hi, everyone. Amy Hinojosa. I'm the president and CEO of MANA, a national Latina organization. We're the oldest and largest Hispanic women's organization in the country with chapters and affiliates across the nation who focus on strengthening Latinas through mentorship, education, and advocacy. We're also a founding member of the Health Equity Collaborative, which is a collaborative of 50 national organizations focused on uplifting principles of health equity, among them costs, right? And one of the things that we've taken on, and this collaborative isn't just a Latino collaborative, it goes across all spectrums of underserved and unserved voices, including African American, AAPI, LGBTQ, patients' rights organizations, chambers of commerce, and really the way we see it is how can we uplift all of our underserved communities in this conversation about health equity. And PBM reform comes right to the top of the list because lowering costs for average Americans is really at top of mind for everyone, especially as we live in this inflationary market and figuring out how folks are making ends meet, right? And you know, the figuring out, I get asked all the time why Latinas care. 1 in 5 women in the United States today is Latina. By 2060, that number will be 1 in 3. We also have the highest rates of, among the highest rates of obesity, heart health problems, diabetes. And so when you talk about the impact on the average person in community, figuring out how they're gonna pay for their healthcare costs, including their medications, Latinas only make 52 cents on the dollar for what a white male earns. Thinking about how they make those ends meet under those circumstances, and then figuring out how, under these inflationary prices and the charges that are being given to them when they go to the pharmacy, figuring that out is of the utmost concern. And so that's how we come to the table, to the conversation, but then figuring out how we look at what's going on in the ecosystem for where the changes are made. Because if someone's being pinched in terms of a cost, someone else is making money. And we want to make sure that we're pinpointing and spotlighting who's doing that so that our folks can make sure that they're able to afford what they need to survive.
Mm-hmm. Marianne?
Hi, everyone. It's a great pleasure to be here. I'm Mariana Sokel. I'm a physician. I'm a faculty at Johns Hopkins University. And all that I do, day in, day out, is to research the pharmaceutical market in the US and how to make drugs more accessible, more affordable to the American people. I mean, as a physician, you know, I'm sure I don't need to tell you that pharmaceuticals are crucial to increase the quality of life of individuals, to expand survival, to prevent disease, to prevent complications. So it is on everyone's best interest that drugs are available. But in this country, my research has found that we do pay, on average, 3 to 4 times more, you know, highest prices than other similar developed countries such as, you know, UK, Japan, Canada, and others. So the question is why? You know, we are the #1 country in terms of research and development for drugs. We have many, hundreds of new drugs coming into the marketplace every single year. And my research has found that, you know, often we hear people saying, well, we don't really pay these high prices for these drugs. You know, the insurers that we hire to represent us in the pharmaceutical market, they are getting better deals. They are getting lower prices. But that's just partially true. You know, my research has found that when individuals pay, you know, for their prescription drugs, whenever they pay cash because their plan doesn't cover the drug, or whenever they pay a deductible because they have a high deductible health plan, or a co-insurance, a percentage. They go to the pharmacy and they're required to pay a percentage of the drug cost. In none of these situations, these individuals benefit from the discounts and rebates and everything that is paid, that is negotiated on their behalf by the insurers. So, you know, patients being always faced with these very, very high prices that nobody else in the world is paying, that's the reason why, you know, often people with very generous insurance still cannot afford their drugs. I've also worked with employers, for example, self-insured employers. And in my research, I have never found a single employer that wants to restrict benefits to their members. Everybody wants their members to have the best benefit. But then the question is, at what cost, you know? And it turns out, in this country, it is the drug manufacturer that does set the drug's price. That's the, you know, responsibility of the drug manufacturer. Whenever they launch a drug, whenever they commercialize a drug, they can decide how much they want to charge for the drug. They can also decide how much they want to provide in terms of rebates and discounts, and they do so by negotiating, you know, with insurers and on their behalf, the pharmacy benefit managers, to get their drug covered. So we've seen in conversations over and over and over, drug manufacturers saying, you know, I cannot lower the price of my drug. That's why prices are high. Because if I do lower my price, the pharmacy benefit managers and these intermediaries cannot make as much as a profit on my drug. That's the case of Humira that Jim very well brought up, and then my drug will not be covered. Humira biosimilars are a good example, right? But my research found that even when we take away, these incentives, these profits that can be made, it's not only about doing savings from not having these profits. It's also about removing the incentive to have a preference for higher cost drugs. So we have hundreds and hundreds of options in the marketplace, but often we see the PBM choosing exactly Humira, exactly the most expensive. We found that by changing these incentives, employers could save, net of all rebates and discounts, between 9 and 15% of the per member per month spending. So the opportunity for real change here is possible. It does depend on changing incentives, but that does have effect, on the end user, which I think is who the person that we most care about is the patients who need these drugs to survive.
Tony.
My name is Antonio Chacha. I'm the president of 3 Axis Advisors and the CEO of a nonprofit organization called 46 Brooklyn Research. I'm a drug pricing nerd from Ohio. I came from the pharmacy world, very perplexed at how the flow of dollars works in the prescription drug supply chain. And to make a very long story short, what we were seeing in the state of Ohio was that pharmacies were getting paid less and less for the medicines that they were dispensing to their Medicaid beneficiaries. But on the other end of the transaction, as those cuts were occurring, the state of Ohio was spending more for their medicines through the Medicaid program. So those two things didn't make sense. How could providers be getting paid less, but the state who's cutting the checks on the other end of the transaction be getting charged more? So we started downloading very boring Excel files off the CMS website and stitching them together to demonstrate that despite the black box of drug pricing, there is enough publicly available information to start providing directional insights. So we started charting all these things together and found a growing gap that existed between the underlying costs of medicines, what pharmacies were being paid, and what the state of Ohio was being charged. We took all of that data and decided to publish it online for free and sat down with investigative journalists at Bloomberg News and the Columbus Dispatch, and it started a cascade of events and dominoes falling, where our state auditor decided to open the books and find that the growing gap that we had identified was worth $245 million in just 1 year of our Medicaid managed care program. What was happening was that PBMs were engaging in a practice called spread pricing, paying pharmacies low, billing the state high, and pocketing the non-transparent difference. What we learned is that, hey, maybe we could save some money with that $245 million. And what we learned is that spread pricing is just one way that PBMs make money and ultimately distort the prices of medicines that we pay as plan sponsors, if you're an employer, or patients as a consumer.
Regarding that on spread pricing, what about, as you said, PBMs have a lot of ways to make money. They're talking to the congressman about how having to put in the legislation very detailed so we're not playing whack-a-mole. Do you think that the current bills, and there are plenty of them, one has passed the House overwhelmingly, will do the trick? And will those savings actually go to the consumer?
I would hesitate to make it so black and white to say this will fix the problem, because there is a multitude of problems, and those problems all range in terms of severity. So, as an example, in Ohio, after they banned spread pricing, again, the difference between what's paid to a pharmacy and then what's billed to the plan sponsor, the state said, hey, that's a lot of money, we're prohibiting that practice. Well, the stocks of the large PBMs never took a hit. What happened was they reacted to the change in policy by overpaying the pharmacy at the point of sale, essentially building up an excess relative to the guarantee that the PBM had to pay to them, building up that excess that could be then clawed back later and then never disclosed back to the state. Furthermore, the other tactic that arose was this practice of specialty pharmacy overcharging and steering. When we talk about PBMs, we ultimately do a disservice to characterize them as standalone entities. PBMs are large, vertically integrated companies that own health insurance lines of business, specialty pharmacies, mail-order pharmacies, retail pharmacies. So if you're a PBM and you're setting the prices of drugs that are dispensed at pharmacies, well, good news, you get to set the prices of drugs that are dispensed at pharmacies you own and the pharmacies that that pharmacy competes with. So what happened was that PBM started overpaying for a number of specialty products that they get to determine that the patient has to get at the pharmacy they own. So I say all of this because just when you think you have the answers, expect that they will change the questions. So policy ultimately is going to be an endeavor in chasing the games and minimizing the perverse incentives for PBMs to act against the interests of their clients.
Mm-hmm. Mariana, you mentioned other countries. What can we learn from other countries? America's very focused on America, but where are there models out there that it would be good for policymakers to possibly mimic?
Well, I think the number one question is how much does a drug cost in the United States? Go to a pharmacy. Good luck figuring that out, right?
Right.
Because the system, there is a benefit from the system not being transparent. Mm-hmm. All these layers of negotiation and invoices and contracts and all these accounting exercises, they provide a service, and the service here is non-transparency, allowing these profits to be made, allowing these clawbacks to be made, and these dollars to kind of go to hands that not always have done the best service to the end user. So I think the number one question here is, we talked about, for example, delinking, PBM right. compensation from the prices and the negotiations they provide. That's linking all of these things together. Whenever you can benefit from changing prices, of course, prices will continue to be changed, and pricing metrics will always be non-transparent. There's a company that I've worked with in my research, and it's really interesting. They're a self-insured employer. They produce software. It's a software you can use for many things, but one of the uses you can have is to manage claims, for example. You can use that software for these environments. When this company talked to their own PBM to say, hey, how much am I spending on drug X? The PBM said, you need to pay me $5,000 so I can tell you. Because that's not part of our contract that I need to tell you at any point in time. I'm due to tell you at this time and only in aggregate with another, drugs in the same therapeutic class. So that's the kind of transparency that we need, and transparency that is based on, more symmetry between PBMs and the companies that hire them. Today, we only have the three largest PBMs. They really concentrate about 80% of the market. So imagine a self-insured employer that is operating, somewhere out there, and they're, really focused on doing the service they're there to do, the company, right? How can they, in good faith, negotiate with one of the largest three PBMs in the country? How can they negotiate? How can they, get a good deal? It's often the case that PBMs say, oh yeah, you're getting the best deal, but how do you even know when there's no transparency?
Amy, as far as the Latina community, the cost of prescription drugs is not a new issue. When I came to Washington, Bill Clinton was president, and he talked about it. We're going to be talking about it for decades. Do you see improvement, big picture, if you pull back? We've had the Inflation Reduction Act. We've had policymakers trying to attack this problem for the longest time, but here we are still talking about the high prices of prescription drugs and what to do with it.
We are still talking about it, and I think that, as we're talking about the transparency of it all, that's what's keeping us from getting to the solution, right? Is that there are, backdoor deals, if you will, being done to increase profits on the PBM side, on the insurer side, and consumers are the ones who pay the price all the time. What sort of the undercurrent of what we're talking about here is that when someone goes to the pharmacy and tries to get the prescription that their doctor prescribed, they're not able to get it if it's not one of the available medications that have been, that the deal was cut for, right? And so change has to come when the doctor who's responsible for your care can prescribe the medication that you need to save your life, not what someone else decides because it's going to increase their profit margins, right? And then how it bleeds into other systems. For example, with the IRA and with so much other legislation, we advocated for the 340B program, right? And making sure that funding goes into community health centers and smaller organizations that are providing care on the ground to the poorest and the most indigent, and the ones who are in the most need. What we're finding is that the PBM intervention is also taking that away. And so we as community advocates have to make sure that our community is being served the way we told them we were advocating for, right? So it almost makes us look like we're part of the problem as advocates when we were advocating for the money to go into community, and now we need to make sure it gets there, right? So what we're talking about really are guardrails, right? We know that these are large systems that have to be negotiated over the entirety of the system, but we need to make sure that the patient, the consumer, is centered in the conversation, because we can talk all around all these issues, but if at the end of the day a person who's sick can't get their medication, we failed.
Mm-hmm. James, a two-part question for you. Number one, the Brookings Institute did an analysis of PBM reform, and they had a couple findings, basically. One of them was the promises of PBM reform may be overstated. Number two, there's a lot of, there are so many big players in the PBM industry, and that is a just criticism of the industry. Can you respond to that? And then the second part of the question is, can you explain how PBMs and employers, the rules that are different for PBMs and employers? Because that's a complicated world.
Sure. I think details matter. So if you're talking about PBM reform, it can mean a lot of different things if you talk to different people. The bill that moved through the House of Representatives doesn't change the way that PBMs do business. It doesn't change anything in terms of the private sector. They'll just send you a report. So you can learn about how much money you just wasted on expensive drugs. Now in the Senate, a number of bills have moved through committee that would actually change the way that those companies do business. And we believe we would see massive savings, and patients would see massive savings on their drugs if those Senate provisions do become law, and we hope that some of them will. Right now, though, many who are studying this are looking at the campaigns that are taking place. They're seeing that a number of former representatives and senators have started writing op-eds about how changing anything about the PBMs will be the end of the world. You'll lose access to your drugs. Your grandma's going to have to eat cat food. Now, hopefully, most in Congress can see through that this is a $15 million campaign that's been going on, and that they do need to make some change. That being said, some things were seen as so complicated that they didn't get included in the legislation. And one of those would be aligning the rules between an employer and a PBM. So your employer, as a fiduciary under the Employee Retirement Income Security Act of 1974, has to be a good steward of the money that gets spent on your health benefits. They can't keep it for themselves. They can't pay excess amounts of money that don't make sense to pay. They have to try to do right by the plan beneficiaries. We said, hey, that's a pretty good set of rules. Maybe we should apply those same rules to the PBM. But the PBM said, well, if you apply those rules to us, our business model will have to change. Like, yeah, that was the idea. That was the plan. But unfortunately, I think in Congress, that was seen as maybe a little bit more complicated than they were ready to do at this time. So for now, step one is try to move those key provisions that have been moving in the Senate. So some are calling it delinking, but the idea is changing the incentives there so that PBMs, instead of trying to make money through arbitrage, they're trying to make money by saving money. That's what you want the PBMs to be doing. And we think transparency is an important part of that. You got to address spread pricing. You got to address the rebates. You got to address these offshore GPOs in Switzerland and Ireland. You've got to do something about the fees that they're charging the pharma companies to participate in your formulary. And you've got to get those formularies to make some sense. If you do those things, you're going to start to see change taking place.
As far as, Amy, we'll go to you on this, as far as what, we talk about a lot of acronyms and the House and Senate bills, and those details are very important, and the implementation of legislation is, I think, underrated. But what's your advice to people who are watching this that are struggling to understand it, and they're just struggling with their bills and inflation, and specifically on drug costs?
Yeah, I think that the first thing is to tell people you're not mad at who you think you're mad at.
What do you mean?
Because I think that it's very easy to just say big pharma is the source of all of our problems, right? And that would be a very easy answer, right? And we can talk about list pricing and how all that's done. But it's this other ecosystem that's occurring, and it's causing these impacts that impact their pocketbooks, right? And so understanding that there's an ecosystem that's taking the rebates that are meant for them, that's taking profits from something that could benefit them. I mean, really, changing this model could put money back in the pockets of people immediately. And so part of what, and I think personally why we haven't been able to get over the line on some of this legislation, right? We've had some great proposals, right? Congressman Auchincloss talked about the latest one, the Drug Act, right? And you have the Pharmacy Benefit Manager Reform Act, the Help Co-Pays Act, the Lower Cost, More Transparency package. All these things are coming to the table, and they have bipartisan support. But what it doesn't have is the support from the community, right? There has to be a groundswell of interest from people in community saying, this is important to me, this could change my life.
Because that will get it over the hump.
That would get it over the hump.
Got a couple of minutes left. Antonio, go to you for maybe closing remarks, if you can keep to a minute.
I mean, ultimately, when people are sitting around their kitchen table saying, talking about affordability, they're not saying, what are the PBMs up to now, right? Of course not. They're sitting there saying, how do I afford my medicines? Conversely, employers are sitting there asking the same questions. How can we continue to provide benefits in a system where the vendor's incentives are in direct conflict with that of the plan sponsor and the patient? The theme here is transparency. The joke, is that you go to a CVS pharmacy and buy a stick of gum, you're going to get a receipt that's a mile long.
Right.
Well, if you spend $1 billion on medicines, CVS will be happy to give you a one-page, one-sided PDF file that says, hey, here's the top 50 drugs that you spent money on. That's not transparency, right? Part of the reason you're seeing this reckoning is because you have people like Mark Cuban's Cost Plus Drug Company that's saying, hey, these prices that you're being charged are bogus and way overinflated, and I'm going to show you my prices online. You can download them at any time. That is creating a reckoning in this industry, and I think that transparency is a very healthy disinfectant.
Mariana, I'll give you the last word, just 30 seconds if you can.
Well, whenever I'm teaching about this topic, people always get surprised that the PBM designs the formulary, but if things go wrong, patients cannot get the drug and go to the hospital, there's no penalty to the PBM. The insurer will bear the cost, the patient will bear the health costs, but the PBM, they got the money and, they did their job. So I agree with this fiduciary responsibility, here, who are we serving? If we're serving patients, that should be the important metric. How is access happening? How is our health changing? And, through all of these practices that we're talking here, I think that's not where we are today.
Great panel. Please thank them for joining us this morning. And I'll hand it back to Sarah. Thank you so much.
Thank you, Bob, and thank you to our panelists. It is now time for our final interview of the morning with Chairman of the House Oversight and Accountability Committee, Congressman from Kentucky, James Comer. Thank you. Here, one more seat.
Hey, Mr. Chairman. How are you? Hey. Yeah. So let me get news of the day, like I talked to Congressman Auchincloss. So your reaction to Super Tuesday results?
I don't think there was any surprise. I mean, to me, it's been clear for quite some time we're going to have a rematch of Biden versus Trump, and I think that Super Tuesday last night pretty much wrapped it up, and that's, for better or worse, what our choices are.
That's where we're headed, absolutely. Okay, question number 2. Investigators in the House, and you're one of the lead investigators, interviewed Hunter Biden. Mm-hmm. Let's make some news, or are we going to see public testimony by Memorial Day from Hunter Biden?
Of course. I mean, he wanted a public hearing.
He's going to get
the Democrats on the Oversight Committee wanted a public hearing, and I want a public hearing. I said we would have a public hearing after the deposition. This investigation's not being conducted any differently than any other major congressional investigation, where you bring everyone in for depositions and then you have a public hearing. Especially with what we have now, there are discrepancies in what 4 of Hunter Biden's former associates have testified with respect to Joe Biden's role versus what Hunter Biden said. So I believe a public hearing would be a good way to let the American people see who they believe, or if in fact, since all the deposition, all the transcripts have been released, everyone that's paid attention to the investigation can digest and pick certain points and determine